Hey everyone, welcome to this explainer. Today, we're demystifying a topic that causes a ton of anxiety. Exactly what a high PSA test result means, and the roadmap your doctor will use to investigate it. We're drawing directly from the deep clinical experience of Dr. Hikatsu, a medical specialist who's treated over 1,000 prostate cancer cases and evaluated more than 4,000 patients with elevated PSA levels. By the end of this, you're going to understand exactly how this diagnostic process actually works, equipping you to make highly informed decisions about your own health. Let's get into it. Here's our roadmap for today. We'll start with why a high PSA isn't a reason to panic, touch on benign causes, walk through the initial tests, highlight the role of MRIs, explain the final biopsy phase, and finally cover the next steps.
All right, part 1. High PSA? Don't panic yet. Let's make sense of those initial numbers.
So you just got your lab results back. You saw a flagged number, and instantly your mind jumps to the worst-case scenario. It happens all the time. But let's take a breath. What exactly is PSA anyway? It stands for prostate-specific antigen. It's simply a tumor marker that's measured via a routine blood test. Generally speaking, doctors start paying closer attention when this number crosses the threshold of 4. But here is the absolutely crucial thing you need to know right out of the gate. A high number is absolutely not an automatic cancer diagnosis. To put this into perspective, look at the so-called gray zone. That's a PSA between 4 and 10. A massive 70% of guys in this range do absolutely not have cancer. 70%. The risk in this zone is roughly 30%. And honestly, even when the score creeps up above 10, the probability of cancer is still only hovering around 50%. Dr. Hikatsu even notes seeing patients with a PSA as high as 30 who were totally cancer-free, right alongside patients with a low PSA of 6 who had highly aggressive tumors. The number alone just doesn't give you the whole picture. Moving right along to part 2, benign causes. Let's talk about the surprising things that can actually trigger a spike. You're probably thinking to yourself, okay, if it isn't cancer, then what the heck is making my PSA so high? Well, keep in mind the prostate is this little walnut-sized gland wrapped right around the exit of your bladder. That location means it's super sensitive to its environment and whatever daily activities you're up to. Believe it or not, everyday things can completely throw your numbers out of whack. Going for a long bike ride? A bumpy road trip? Yep, that mechanical stimulation from a saddle or a car seat can agitate the gland. Same goes for prostate inflammation, a urinary tract infection, or even just an enlarged prostate, which is known as BPH. Oh, and here's a big one. Failing to hold off on ejaculation for a few days before your blood draw can artificially inflate your score. Context is literally everything here. Okay, section 3, initial tests. This is where the medical detective work actually begins. So if your doc suspects your spike is just noise, they are definitely not going to rush you into surgery. Instead, they kick off a non-invasive investigation. First step, just wait a month. It sounds crazy simple, but giving it 4 weeks lets any random inflammation or infection clear out. When you go back, they'll retest your urine and your PSA. If the numbers are still running high, you'll probably get an ultrasound, sometimes called an echo, to see if the prostate is just benignly enlarged. But here's the catch. Dr. Hikatsu warns that ultrasounds are kind of notoriously bad at spotting early-stage cancer. They really only show advanced bumpy tumors. Because of that limitation, doctors will often order some more specialized blood work. One of the heavy hitters in that blood work is the Prostate Health Index, or PHI. Now, the magic number to keep in mind here is 27.2. If your PHI score creeps over that line, the probability of cancer does go up. But, and this is important, it's an advanced calculation and it's not totally bulletproof. It can still miss about 10% of cases. So even if your score is below 27.2, further investigation might still be on the table based on your specific clinical profile. Now, what about the physical check? The digital rectal exam or DRE. While some docs still do this early on to feel for hard lumps, Dr. Hikatsu actually points out that early cancers are almost never felt this way. In fact, he often completely skips this super uncomfortable exam during the first outpatient visit. I mean, a smooth-feeling prostate definitely does not guarantee you're cancer-free, and if you end up needing a biopsy later, you're going to have that exam anyway. Why put yourself through it twice if it isn't definitively helpful yet? Which brings us to section 4, the crucial role of MRI and how we visualize the prostate safely. This right here is an absolute game changer for modern diagnostics. We're moving completely away from blind guessing and stepping into high-definition clarity. An MRI grades your prostate using what's called the PI-RAD scoring system on a scale of 1 to 5. A 1 means cancer is highly unlikely, while a 5 means it's highly likely. It's amazing because the doctor can literally see if there are suspicious lesions, pinpoint their exact location, and measure their size, all while you just chill comfortably in a scanner. Highly accurate, totally non-invasive. Dr. Hikatsu is incredibly passionate about this. His golden rule: a high-quality MRI should absolutely be used to rule out false alarms and help you dodge unnecessary, painful procedures whenever possible. He notes there's still some doctors practicing what he calls strong-style medicine, meaning they rush straight from a high PSA blood test right into jabbing needles into the prostate. Seriously, if you find yourself on that path, you need to advocate for yourself. Explicitly ask them for an MRI first.
Let's move to Section 5, the final test, the biopsy and the ultimate confirmation. So if the MRI does unfortunately light up with suspicious areas, the final step in this journey is the prostate biopsy. Let's be real, this is the only way to get a definitive black and white microscopic confirmation of cancer. But it is a major procedure. Doctors use an ultrasound probe inserted into the rectum to guide needles either straight through the rectal wall or through the perineum, that's the space between the scrotum and the anus, to grab tissue samples. Because it's highly painful, you'll be given anesthesia. That could be IV sedation, a spinal block to numb your lower half, or localized shots, and it often requires an overnight hospital stay.
And this is exactly why doctors rely so heavily on MRIs first. Biopsies carry some very real risks. You might deal with hematuria, which is just blood in your urine for a bit. But more concerning is urinary retention. The prostate swells up from the needle punctures and can actually squeeze your urethra shut, meaning you might need a temporary catheter just to pee. And the absolute scariest risk? Sepsis. If bacteria from the rectum hitch a ride into your bloodstream during the puncture, it can trigger a systemic, life-threatening infection. Definitely not a casual first step. Okay, Section 6. Next steps. Mapping out the path forward after a diagnosis.
If the biopsy does confirm prostate cancer, the investigation seamlessly shifts to staging the disease. The question changes from, is there cancer, to, has it spread anywhere else? Just to make sure you're fully informed of the entire process, doctors rely on two main scans post-diagnosis. You've got the CT scan, which checks your major organs and lymph nodes, and then you have bone scintigraphy. Since prostate cancer loves to spread to the bones, this specific scan is vital for mapping out a treatment plan. Though it's worth noting, for very low risk, super early stage cancers, doctors might safely skip the bone scan entirely.
Now, as a final caveat to this journey, there are a few extreme scenarios where doctors might skip the biopsy altogether. We're talking about rare cases where a patient comes in with an astronomical PSA, like 1,000 or 3,000, and their MRI and CT scans clearly show massive tumors spreading to the lymph nodes. If that patient is on critical blood-thinning medication that they literally cannot stop taking safely, doctors won't risk a biopsy. The imaging and blood work are definitive enough to just kick off treatment right away. So here we are at the end of the roadmap. Armed with this knowledge, you can face the medical field feeling totally empowered. You now know the difference between a random benign spike and a genuine risk. You know exactly why demanding an MRI before a biopsy is one of the smartest moves you can make. The next time you're staring at a flagged routine lab result, will you panic? Or will you see it as just the very first clue in a medical mystery that you actually know how to solve? Thanks so much for joining this explainer, and stay curious out there.